Hello, this is Patrick Graby. Today is the 21st of September of 2020. There's my little sheet there. You can see that. So this is the Unit 2 case studies. Um, I chose two of the cases, Case 1 and Case 3. And Case 1 talks about pyruvate kinase. And how it's regulated, and so we have obviously two types of regulators, inhibitors and activators. So pyruvate kinase is the enzyme that takes PEP and makes it into pyruvate, and so it's fairly important enzyme, and it's inhibited by things that if we don't need any more energy in the body or in glycolysis. So it's inhibited by increased levels of ATP, acetyl-CoA, long chain fatty acid CoA, and glucophosphokinase. So those are things that inhibit it on a normal basis. We have enough energy, we have enough ATP. Those are things that will slow it down. There is one inhibitor, arsenic, which will also inhibit pyruvate kinase, excuse me. And obviously that's a poison. It's not something that we take in every day, but that is one thing that will inhibit or regulates that by inhibiting it. Two activators that we have. One activator is insulin. It dephosphorylizes pyruvate kinase, excuse me, and that's so that we can, it increases its. We need more energy produced in the body, and so insulin increases that increases that stimulus of PK to get ready to go to produce more. The other one is kind of a feed-forward type mechanism. It is an activator, but it's fructose 1,6-bisphosphate. And the idea behind that is as it gets produced, levels of that can zip over and activate pyruvate kinase, kind of telling the system, hey, there's a lot of fructose 1,6-bisphosphate coming, and you better get ready, get prepared for that. And so those are kind of the two separate, the inhibitors and the activators for that pyruvate kinase is regulated by. The second part of Case 1 was interesting to me, was about cancer cells and how cancer can promote expression and change it to make it a more favorable condition for the cancer cells itself. And this was pyruvate or PKM2 over PKM1, pyruvate kinase model 1 or M1 over M2, M2 over M1. And what's the rationale for this, and what other pathways may cancer cells develop or divert substrate to, So it's pretty interesting, the whole cancer thing. So PKM2 in its dimer phase, or low activity, facilitates production of glycolytic intermediates to enter glycolysis branch pathways, both glycerol synthesis and the pentose phosphate pathways, which produces NADPH, but it also suppresses the reactive oxygen species, or ROS, production, which is involved in nucleotide synthesis. So it kind of starts out, and it what I'm going to discuss or talk about here is just the ability of the cancer to pick which pathway it wants, or which enzyme that it wants to use, and it's pretty it's pretty interesting that cancer has the ability to do that. That's why it's such a complex disease to fight or to treat. So three ways that it does this. One, a phosphorylation of the PKM2 at tyrosine 105 induces the release of FPB, which causes PKM2 to alternate between dimeric and tetrameric states. So this means that it, instead of just being in one state, the tetrameric state, it forces it to go back and forth, thereby being in more of a low active state to produce more PKM2, or to allow it to further. Excuse me there, little breeze. So it phosphorylates PKM2 at tyrosine 105, which causes the PKM2 to alternate between the dimeric and tetrameric states instead of saying just tetrameric, which the dimeric is the dimer phase, or the dimeric part is what helps cancer out. So it wants to keep that, so that's why it's there doing that. Acetylation of PKM2 at lysine 305 downregulates PKM2 activity, which promotes glycolytic pooling and NADPH synthesis and tumor growth. So therefore, the acetylation there is producing tumor growth. So yeah, that's an interesting thing for that to happen. And then lastly, the oxidation of PKM2 at cysteine 358 gives an advantage to cancer cells by allowing them to withstand the ROS. And so these three things here is what cancer can turn on or turn off and use to its advantage in the body, and it does so. And so that's why, although it seems really weird, we would want the PKM1, which seems to be a better expression than the PKM2. But for cancer, it wants to be able to grow by itself, and so if it can reduce those oxygen species and how it can do that, better tumor growth for itself. It doesn't take more energy to get rid of the ROS, and so that's why it does it, or at least that's from my interpretation of what I've read. So case 3. Case 3 is a presentation of a 5-year-old male appearing sickly and drowsy. Mother notes patients had polyuria and polydipsia. In a test run, the serum insulin levels are significantly low at baseline and 1 hour after glucose. That's according to the case 3 notes. From my understanding, a low insulin, polyuria, polydipsia, and the fact that the patient's drowsy are all indicative of the patient having diabetes mellitus. Further testing should be considered before diagnosis is made. There should be some genetic testing as well, just to ensure that this is a correct diagnosis. But my prediction for the fasting blood glucose level for the patient's current condition, I'm presuming that it's going to be elevated well above the 120 milligrams per deciliter. A couple of things that I looked at: the absence of glucagon will not be antagonized. With the absence of insulin, glucagon will not be antagonized. So this results in an increase in gluconeogenesis from amino acids in the liver. Also uninhibited, it will glucagon will increase lipolysis in adipose tissue, and as low insulin condition continues, the body will use fatty acids and keto acids for fuel. So yeah, this case this would appear to be a type 1 or early onset diabetes case, 5-year-old appearing sickly and drowsy, with all the signs and symptoms of what you would consider classic diabetes, with the serum insulin levels. There should be some other testing done to ensure that, okay, the insulin levels are low. You could do an A1C and check those kind of things out to see what is, 3 months. Is there something going on? Is this a new onset? Was this glucose level high? Was the A1C better 3 months ago, or is it just this is the way this child has been since he's 5 years old? But this would typically present. This is typically how I've seen diabetes present in young people, treated several patients such as this. So that's all for the Unit 2 case studies, Case 1 and Case 3. Thank you.